Okay, let's talk about some specific examples of hydrostatic pressure and colloid osmotic pressure in blood vessels. So this is an example of a capillary, and we've got blood flow going in this direction, and that's what this arrow right here is indicating. And so blood's going to come out in this direction. So we can talk about this side of the capillary bed being the arterial end, because we're feeding blood into it, and blood's going to travel through that capillary bed or that capillary and then come out the other side, which is going to be more the venous end. And it's going to join together into venules and then veins and then head back to the heart. So this is kind of our direction of flow. So if we look at these different numbers, we can actually put numbers on our hydrostatic and osmotic pressure. So here we're given a net hydrostatic pressure of 35 millimeters of mercury. So I'm going to put this here because that's our pressure unit. So we have an outward pressure of 35. Okay, and so this is a pressure that's being created by the blood that's contained within this vessel pushing outwards. Right? So all along here it's pushing outwards, and it's pushing out with a pressure of 35. Now we also have osmotic pressure, which is what this is showing you here, and you're given a net osmotic pressure of 25 millimeters of mercury pulling back in or sucking fluid back into the capillary. And if you think about what causes that osmotic pressure, it's being created by non-diffusible proteins and other large molecules that are inside the capillary that can't leave. And so they're going to suck fluid back in, and that creates this inward pressure. So on this side, if we kind of even draw a line separating the arterial and the venous end, what we have going on this side of the capillary bed is we have an outward pressure of 35. We have an inward pressure of 25. These pressures are moving in opposite directions, right? They oppose one another. So we can actually subtract these two pressures. 35 minus 25 gives us a pressure of 10 millimeters of mercury. And the pressure of our net filtration pressure, which is when we account for both hydrostatic and osmotic pressure, we end up getting a net filtration pressure. What is the overall direction of pressure? And it's going to follow the same direction as the larger of the two pressures. So this 35 is larger. Pushing out was a larger pressure or a larger force than pulling back in. So this net filtration pressure on this end of the capillary bed is going to be 10, and it's going to be pushing fluid out. Okay, so we're going to say pushing out of the capillary. And we call that filtration. Okay, so when we're going from inside the capillary to out, we call that filtration. And that's exactly what we see. So if you look here, we end up having net filtration at the arterial end of the capillary bed. And that is a general truth that we see with capillaries. And that's just because the hydrostatic pressure is increased and it's pushing fluid out of the capillary. Okay, let's look and see what's happening at the venous end of the capillary. So at the venous end of the capillary, one of the things to think about, if you can kind of picture it, is the whole time that blood is flowing through this capillary bed, fluid is being pushed out the whole way across. Okay, and so we end up having at this end of the capillary decreased fluid inside the capillary because more of it has been pushed out the whole time it's been traveling down the capillary. It's been pushed out. Okay, so we actually are going to have decreased fluid inside the capillary when we get to the venous end, and that ends up resulting in a decrease in hydrostatic pressure. So look, our hydrostatic pressure went from 35 down to 17. Okay, so what we see at the venous end of the capillary is we have a decrease in hydrostatic pressure. Okay, now, but we still have some, so we have an outward pressure of 17 pushing out of the capillary. Now, what's going on with our colloid osmotic pressure? Well, if you look, it's at 25. It's also at 25 here. So it doesn't really change. It actually stays pretty constant because what's causing that colloid osmotic pressure? Well, it's being caused by proteins that are non-diffusible. So they were located here. Well, they're non-diffusible. They're not going anywhere. So they're still over here as well. So they're still exerting that same inward pressure. So we continue to have a net osmotic pressure of 25 pulling back in again. Okay, so we'll say osmotic pressure stays the same. Okay, and that's kind of important. So we'll say proteins didn't go anywhere. Okay, they are non-diffusible. So that's kind of the definition. So we've got an outward pressure of 17, an inward pressure of 25, and they're opposing again, so we can actually subtract the two of these, and we're going to end up with a net filtration pressure of 8 millimeters of mercury. So what I tell my students, you can calculate this as a negative because I realize 17 minus 25 actually gives us a negative 8. I find some students find that confusing. Other students are fine with it. It honestly, it's not going to affect any of your answers on questions. The main thing that you need to know here is that what direction is this net filtration pressure in? So since our osmotic pressure pulling fluid into the vessel was higher, then this pressure, this net filtration pressure, is going to be in that same direction. So this is going to be 8 millimeters of mercury as a net filtration pressure, pulling or sucking fluid in to the vessel, and we call that reabsorption. Okay, because we're pulling fluids back in. And that's exactly what you see if you look up here. We have net reabsorption at the venous end of the capillary. Okay, that's what's happening there because this is why our hydrostatic pressure decreased, but our osmotic pressure stayed the same, and it changed that net filtration pressure. Okay, and so this is why, if we look back at here is blood flow. So this is really our arterial end of the capillary bed. This is going to be the venous end. Okay, because we've got blood flow in here. Now, due to this high hydrostatic pressure on the arterial end, we see net filtration on the arterial end, and that's what we see. We see this large hydrostatic pressure, net filtration, so that 20 liters of fluid gets pushed out. But then as it's traveling through the capillary bed and that fluid is out in the interstitial space, because by the time we get to the venous end, we have net reabsorption, we pull back a lot of that fluid back into the capillary, 17 liters or so, right? So because we have a net reabsorption at the venous end of things, we're able to recapture most of that fluid. But this is basically summarizing all the details that we just went through here. So what happens when this goes wrong? Well, what we see is edema, which is a fancy word for swelling. Okay, so if you've ever seen patients with feet that look like this, you know, maybe after surgery, or if they have other types of injuries, you can see kind of, we would even call this pitting edema. You can see fingerprints. You know, this is fluid so bad that when you indent it with your finger, it actually stays indented. So this is edema, and if you've worked with patients at all, you've probably seen this. But what's causing that? So it can be caused by two things. It's basically an abnormal increase in interstitial fluid. So, you know, we've got our capillary bed, kind of like that other picture. Well, here's the capillary. Well, this is going to be our interstitial fluid out here. So if we have edema, it's either being caused by an increase in capillary hydrostatic pressure, So we can say hydrostatic pressure increases. And when would that increase? So maybe if you have someone who has high blood pressure or hypertension, right? They have increased blood volume, and that's going to result in an increase in blood pressure, right? Let's say you eat a lot of salt. You eat like a whole bag of chips, and you retain a lot of fluid because of that. That's going to result in an increased capillary hydrostatic pressure. Or we can also see if you have a decrease in capillary colored osmotic pressure. So if we have a decrease in that reabsorption force, so decrease in osmotic pressure. So when would that happen? This is where your injuries come into play. So if you have an injury, like you break your leg and you rupture all these blood vessels, well now, let's say that this blood vessel is ruptured, in all these different places, right? So the walls aren't continuous. Well, what's happening? Those non-diffusible proteins are no longer non-diffusible. They can just leave, so you can have proteins out here in the interstitial fluid, and they're going to pull the fluid out with them. And so that's going to create more swelling in that interstitial space. So those are the two reasons why you would see edema, that would look something like this. Okay, so now we're on the vein side of things. So we've done arteries, we've done capillaries, and now we're on the veins. And so veins are going to be responsible for carrying blood from the capillary beds back up to the heart. Capillaries, when we travel from the arterial end of the capillary bed, here's our capillaries, and then we've got venous blood going back up the other side. That capillary bed is going to be draining into a venule, okay? And so the capillaries are going to join on the venous side of things to form a venule, and the venules are going to join to form veins, and then larger veins, and then back to the heart. Okay, and so this is what that looks like too. Here would be your venule draining the venous end of the capillary bed. So veins do have all three tunics. They still have intima, media, and adventitia, but their walls are generally thinner. Veins tend to be really loose and kind of floppy. They don't have a lot of structure to them like arteries do, because they don't have much in the way of smooth muscle or elastin in their media layer. Veins tend to have really large lumens. They tend to be, when you see them in cross section, I'll show you in a minute, they tend to be kind of floppy looking, where arteries look very structured, okay? Veins tend to hold most of our body's blood volume at any one point in time. So they are basically responsible for holding about 65% of the body's blood at any time. Now, because they are so, kind of loose and floppy, they need help getting blood back up to the heart. Against gravity. Okay, because gravity is constantly, pushing the blood down. If here's your legs, right? Gravity is constantly pushing blood down, and it's going to want to pull in your feet. Well, we need help being able to get that blood back up to your heart. And so one of the adaptations that we see with veins is valves, which are going to be little folds of the tunica intima. Okay, and so they create these valves. They're just like the heart valves. They work very similarly to the heart valves in preventing backflow. Okay, so comparison of arterioles and capillaries and veins there. This is just a reminder, like what I said before, most of the blood in the circulatory system is contained in veins. So really about 60 or 65% is contained in the veins at any one point in time. This is looking at a cross section of arteries and veins. So you can see here's a vein. This is an artery. Look how much structured the artery looks. Look at this nice thick tunica media. Tunica media on the vein side is very thin and very floppy. So definitely some differences with those. And this is a kind of a good highlight too. With both of these pictures, we've got a vein, here's a nerve, and here's an artery. And same thing on this side. Here's an artery, these are nerves, and here's a vein. And this is basically how structures are arranged in your body. Basically, arteries, veins, and nerves all travel together. We call this like a neurovascular bundle. And you find this throughout the body, that they're always kind of paired up like that. So veins or valves in the veins are there to prevent blood from flowing backwards. They are created by folds in the tunica intima. We typically see this in veins of the extremities, meaning the arms and the legs, to prevent backflow. And so this is basically what it looks like. So you've got, they basically look like semilunar valves, right? They're kind of arranged just like semilunar valves. So what's going to happen is, and you'll find too that veins tend to be embedded in muscle. So as the muscle contracts, and that's another way that we have help with veins, muscles are going to contract, and it's going to take blood from maybe this area and push it through the vein up to the next segment. Okay? Now, what's going to happen is after the blood pushes through, some of the blood is going to push back against the vein or against the valve, and those valve flaps are going to close behind it. So it's going to, it kind of goes segmentally. Like if we have, this is our whole vein, and here's a valve. We're going to come up a little ways. There's another one, and another one, and another one. And as soon as the blood pushes through one, it's now here and it can't push back. Now it's going to push from this segment up to this segment. And now it's here and it can't push back. So it's basically very segmental and making its way up through the valves, or through the valves up through the veins and the legs. This is what happens when things go wrong with that. You've probably seen patients or maybe family members or maybe even yourself having varicosities like this. This is what happens when the valves become incompetent. Just like in the heart, it can happen in your legs as well. And so what happens is basically, here's your vein, and if we have a valve that doesn't close, completely, then blood that's been pushed up through this valve has the opportunity to push back down again, come back down again, and it can fill up this area and actually end up distending the walls of this particular area, of that vein. And that creates these varicosities in the veins. So you see it more with, you see it with pregnancy. You see it with people with cardiovascular disease. You see it with people who have gained weight, people who sit a lot at their work because again, gravity is constantly pulling blood down. And if you don't get up and move around and stand up and get some muscle pumping going, that blood can just pool in your legs. So that's the types of people that you would tend to see this with. There is a genetic component as well. So you see it with some people because of genetics. This is another interesting aspect of blood vessels, and these are called anastomoses or anastomosis. What you'll find with blood vessels is that blood vessels tend to be highly redundant. So on the arterial side of things, we are basically going to see arteries that really, interconnect and create these networks where we have multiple arteries traveling to the same area, and then they're going to connect and form these kind of redundant blood flow. Okay, and we typically see this to important areas. So these arteries are going to form a redundant blood flow to important areas. Okay, like the brain, which is one. So circle of Willis is a specific arterial anastomosis that we see in the brain where we have multiple blood vessels traveling in. I realize this is the hand, this is not the brain, but this is kind of showing you here. You've got radial artery, you've got ulnar artery traveling in, and then this is your connection. And that's what I was trying to kind of show you here. Here would be like radial artery coming in. This would be ulnar artery coming in, and we've got a connection between the two. So what happens with arteries is that if you lose blood flowing into that area from one vessel, it can always, or it has an opportunity to continue to receive blood through another vessel. And that's what we mean by redundant. Okay, so you have blood flowing into an area through more than one route. And it's basically like if you were traveling in your car and a road was closed down, if they had like a bypass. Okay, and that's kind of what we see here. This would be like a bypass. Now, on the vein side of things, there are lots and lots of anastomoses. They tend to be even more common. So on the venous side of things, we are basically going to see multiple routes for venous drainage. Okay, so this is blood being, drained from a particular area. And we have lots of these throughout the body. So, where arteries, it's not quite as common. Venous anastomoses are very, very common because there's tons and tons of veins in the body. So, and they usually make these connections to drain specific areas. Okay, so let's talk about some factors that affect circulation. So these are going to be 3 factors that affect circulation, blood traveling through these blood vessels. So we've got blood flow, we've got blood pressure, and we've got resistance. So 3 factors, let's talk through each one of those. So here's our first factor. Here's blood flow. Blood flow is defined as the volume of blood that's flowing in a given period of time. Okay, so we have a volume over time. And so we typically express blood flow as milliliters per minute. So here's our volume and here's our time. Okay, now we can look at blood flow and we can say, well, how much blood is going to a specific organ, or how much blood is flowing through a specific blood vessel, or how much blood is actually flowing through the entire cardiovascular system. And in that case, we would be looking at cardiac output. So if we look at cardiac output, just to define that, cardiac output is going to be heart rate times stroke volume. Okay? Meaning heart rate is how many beats per minute times stroke volume, which is how much blood does the heart pump out with each beat. So stroke volume is defined in milliliters per beat. What's the volume of blood that's ejected from the heart with each heartbeat? So these guys are going to cancel out, and we're left with milliliters per minute. And that's cardiac output. So this is an example of blood flow, right, in milliliters per minute. So cardiac output is basically looking at blood flow to the entire body. And we can tease that out a little bit, and we'll talk about this some, but basically cardiac output to the whole body remains fairly constant. But what we can do, what we do have control over, is changing blood flow to specific areas. So like if you go and you eat Chinese super buffet, you can increase blood flow to your gut to help you digest that. But if you're laying on the sofa because you ate too much, then blood flow to your leg muscles is going to decrease because you're not using them at that point, right? So we're able to change blood flow going to specific areas of the body based on what we need. Here's your blood pressure. So blood pressure, force per unit area exerted on the vessel wall by the blood contained within it. And this should sound kind of familiar, right? We kind of drew this level. This is the lumen of our blood vessel. We've got the blood inside it pushing out. And we also call this hydrostatic pressure. Well, blood pressure is an example of hydrostatic pressure within blood vessels. The units are millimeters of mercury. And basically, when we talk about cardiovascular system, we mean our systemic arterial blood pressure that we could measure in the largest arteries near the heart. And so typically, like when you go to the doctor's office and they take your blood pressure, it's being taken at the brachial artery, which is a fairly large artery near the heart. So it gives us a pretty good indication of the highest pressure, and it's very doable in a clinical setting. So it wouldn't be really friendly to do an aortic blood pressure because that's highly invasive, every time you go to the doctor's office. So brachial artery is kind of the next closest thing. One of the things to keep in mind is that blood always flows from high pressure to low pressure. So it's going to flow down this pressure gradient. So if we have, high pressure, blood's always going to flow down that gradient to low pressure. And, like this, for example, would be a larger gradient than, let's say, something where we didn't have quite as much of a, downhill. Like this slope is much less than this slope, right? So this is going to have more of a gradient, a pressure gradient, more of a difference between high and low. This is going to have less of a difference between high and low, so less of a pressure gradient. And that's going to come into play when we look at blood flow and velocity through the circulatory system. So blood always flows from high pressure to low pressure. This is true in the circulatory system, and we also saw this true in the heart. So pressure gradient drives the circulatory system and blood flow in the heart, right? So everywhere we see this as a way that blood is moved. And then our third factor is going to be resistance. So what is resistance? When we talk about resistance, we basically mean opposition to flow. And we can even define this as peripheral resistance, which is basically the resistance that we see in all the blood vessels in the body. And this is friction. So the walls of the blood vessels create friction that affects the flow of blood through them. And there are three sources of resistance in the body. So viscosity, blood vessel length, and blood vessel diameter. So there are three different factors that play a role here. So this first one is viscosity. And viscosity is basically resistance to flow. So if something is more viscous, it does not flow as smoothly, or it has increased resistance. Okay? So blood is more viscous than water. Let's see. Ooh, hold on. No. Okay. Blood is more viscous than water. Okay? Blood is thicker, kind of like this honey here. It's thicker, so it has more resistance to flow. An example of increased viscosity, if you think back when we talked about blood, polycythemia, remember, increased red blood cell? Well, those red blood cells being higher than normal creates increased viscosity in the blood vessels. And if we have increased viscosity, then we have increased resistance to blood flow, and that can be problematic. The second one is blood vessel length. So the longer the vessel, the greater the resistance. Because if we had just a little short vessel here versus a really, really long blood vessel, well, the blood inside that blood vessel, right, is meeting resistance from the walls of that blood vessel the whole way, as it's traveling the whole way down the vessel. So the longer the blood vessel, the more resistance that blood inside the vessel is meeting and trying to overcome against the walls inside the blood vessel. Okay, so the longer the vessel, the greater the resistance. So this vessel here would have increased resistance. This vessel, relatively speaking, would have decreased resistance. And then blood vessel diameter. And so this has to do with how, big your blood vessels are, right? So we're talking about lumen size. Okay? So now what happens with this is that if you look at blood flow, the blood flowing next to the walls of the vessel is going to flow slower due to resistance than the blood flowing in the center. Okay, so this blood out here is flowing slower, okay, due to increased resistance. And so if you have smaller vessels, you have more blood inside that vessel that's in contact with the wall of the vessel. Therefore, you're going to have increased resistance because of a decrease in diameter. Okay? If you have a larger blood vessel, okay, you can have much more blood. Let's say all of this blood here in the center is flowing really smoothly, and it's only this blood out here on the periphery that's meeting resistance. Well, we have much more blood that's flowing smoothly. So we're going to have decreased resistance because of the increased diameter of this blood vessel. Okay? So your relationship here is going to be, if we have the diameter of a blood vessel decrease, resistance is going to increase. So they are inversely related to one another. If we have the diameter of a blood vessel increase, then resistance is going to decrease. And it's the same, I usually give the example in class about, let's say, like a bubble tea straw, right? Or a little coffee stir. So bubble tea straws are going to be your larger diameter blood vessels. They have decreased resistance. A little coffee stir, if you're trying to drink anything up out of those, they have decreased diameter, so increased resistance. Okay, and this is just pointing out laminar flow is nice and smooth within blood vessels. Sometimes we have turbulent flow. Maybe if you have atherosclerosis or like plaque buildup on the walls of your blood vessels, it affects the flow and it creates turbulence, which also can be problematic. But this right here, now we've just kind of narrowed, this diameter here, we just increased resistance to blood flow through that area. And that can certainly cause problems. Now, our next topic is going to be blood pressure. So blood pressure, and again, this is basically our hydrostatic pressure. We have two arterial blood pressures that we can talk about. We have systolic blood pressure, which is going to be the blood pressure during ventricular systole when the heart contracts. Okay, so this is basically going to be your highest pressure because it's during heart contraction. The diastolic blood pressure is going to be the blood pressure during ventricular diastole. And because this is the pressure when the heart is relaxed, this is going to be the lowest blood pressure. Blood pressure is very cyclical. So you'll see it's going to kind of peak and then travel down, and then peak and then come down and peak. So up here at the top, this is going to be our systolic blood pressure. And we typically see, an average of around 120 millimeters of mercury. Our low points are going to be our diastolic blood pressure, and they're going to be down around 80 millimeters of mercury. Okay, so 120 over 80 would be a typical blood pressure. Studies have shown that a systolic pressure above 127 damages the tunica intima and can cause issues with that. So if you think about that, if you work in a clinical setting at all, many of our patients come in with blood pressures much higher than 127, and if you keep it elevated above that for an extended period of time, it can certainly be problematic. So what kind of relationship do we have here between pressure, flow, and resistance? Those three factors that we've been talking about. So here's our flow. Blood flow is directly proportional to change in pressure or pressure. So by change in pressure, we basically mean a point in time. You remember how we talked about blood flowing from high pressure to low pressure? So here's our high pressure, here's our low pressure. So we can take a point here and we can take a point here, and the difference between these two is going to be our change in pressure. Okay? So we can talk about change in pressure, or we'll eventually just say, okay, we're just going to say pressure here. So flow is directly proportional to pressure. So if pressure increases, blood flow is going to increase. They have a direct relationship. Flow is going to have an inverse relationship to resistance. So this means that if resistance increases, then flow is going to decrease. And that makes sense. So if you're trying to drink out of the little straw, right, versus the big straw, in this scenario, we have increased resistance. What's happening to our flow? It's going to decrease. So this relationship between flow and resistance is going to be inverse. Now, one of the things to keep in mind is that resistance is really easy to change in our body. In fact, we can change it really, really quickly because we have a lot of control over blood vessel diameter. So this is kind of really, really important. And this is how we control a lot of blood flowing throughout our body, by changing blood vessel diameter, because we have that smooth muscle layer, that tunica media, and it's able to contract and decrease diameter, or it's able to relax and increase its diameter. Okay, but this is basically where it's all coming from, that tunica media layer, and it gives us a lot of control over blood vessel diameter. So here's a graph on pressure changes that we see throughout the cardiovascular system. So if you look, we're starting in the aorta, so the largest artery in the body. We're going to travel along the cardiovascular system. We go down to capillaries, and then we come back up the venous side of things, and then back to the heart. So what happens here? Here's blood pressure. Okay. Now, if you look at the aorta, this is basically the highest point of pressure in our cardiovascular system, right? And we see this fluctuation because this is pulsatile. So as the heart beats, it sends out these waves of blood into the aorta, and we see a peak in pressure, which we know is going to be our systolic blood pressure, and then we see a low point in pressure, which is our diastolic blood pressure. Okay, so we're going to see that pulsatile. That is also because the aorta, if you remember the type of artery it is, it's an elastic artery, and it recoils. And this is basically showing you that recoil. It's going to extend or expand to accommodate all the blood coming from the heart, and then it recoils. And then it expands and then recoils, and it does that with every heartbeat. But we basically see the highest amount of pressure in the aorta, and then the pressure is going to start to fall, and it falls down to about 35 as we hit capillary beds. And then look what happens on the venous side of things. It actually falls even more. And as we travel down the venous side of things, we're very, very low pressure. So generally we see low pressure on the venous side of things. In fact, to the point where when we get back to the heart, heart pressure in the right atrium is going to equal 0. There's really no pressure there. And we need that because we need to have this pressure gradient in order for blood to flow. But you can also see look how steep this curve is here. A much higher pressure gradient on the arterial side of things, a much lower pressure gradient on the venous side of things. And this is why veins need help. right, to get blood to flow through them. Veins need help because they have a much lower pressure gradient. Their curve is much flatter here. You know, there's not much difference between here and here. Okay, so what factors can affect arterial blood pressure? So basically, it's affected by two different things. One of the factors is the compliance of the elastic arteries near the heart, and this is basically the fact that the aorta and the other large arteries are elastic arteries, so they can expand and recoil. Okay, so they're able to do that because of the elastin in their tunica media. And the aorta has a large volume of blood that's being pumped into it, and that's why we see that pulsatile tracing here. That's what we mean by this. This is pulsatile, high and low. Okay? Good. And that's what we see here too. This is basically the same thing. This is the pulsatile change in blood pressure. Here's blood pressure here on our y-axis. Here's systolic pressure that we're going to see. That's going to be your peak pressure generated by systole, ventricular systole. Here's our lowest pressure that we see in the cardiac cycle, and this is going to be diastole. And then we can actually take kind of an average of the two, and we call this our mean arterial pressure. Okay, and so this is going to be basically the average of the pressure in one cardiac cycle. So average pressure in one cardiac cycle. Okay, and so if you notice, your mean arterial pressure is a little bit lower. It's a little bit more towards the diastolic pressure than systolic pressure. It's not a halfway point in between the two. So why is that? Well, it's because the heart spins longer in diastole than it does in systole. So it's not a halfway point because the heart it spends more time in diastole than in systole. So we can say diastole time, or time in diastole, is larger than time in systole.